Short-term plans are a valuable option for individuals and families to gain financial protection and health coverage. According to a study from Chris Pope at the Manhattan Institute, for equivalent insurance protection, the premiums for short-term plans are much cheaper, much lower than ACA plan premiums, sometimes half the cost. Moreover, short-term plans generally cover far more providers. The fact is that the ACA hurt a lot of people, substantially increasing premiums and deductibles for plans that cover fewer doctors and hospitals. Short-term plans are an attractive source of coverage that will help many of these individuals and reduce the number of people without health insurance coverage. In fact, they have helped my wife and our 5 children. We are currently covered under a short-term plan. By permitting people to purchase short-term coverage for up to 36 months, you would provide Kansans with additional options with more protection. Some warned that short-term plans would harm the ACA individual market as healthy people migrate to short-term coverage. This is something that can be studied because states take different approaches with respect to short-term plans. I studied this issue, and the Galen Institute released my study last month. It turns out that states that fully permit short-term plans have had better enrollment, insurer participation, and premium trends in their ACA individual markets than states that restrict short-term plans. For example, there's been a 61% increase in the number of insurers offering ACA plans since 2018 in states that fully permit short-term plans versus only a 25% increase in states that restrict short-term plans. And while premiums have declined overall since 2018, the decline in ACA plan premiums has been twice as large in states that fully permit short-term plans. Why does permitting short-term plans help the individual market? First, less adverse selection in the individual market occurs. People who develop medical conditions while enrolled in short-term plans have their expenses covered by the short-term plan instead of switching to an ACA plan. In essence, by allowing people to keep plans for 36 months, you're making them more valuable and allowing people more financial protection. Second, competition from short-term plans should spur individual market insurers to become more efficient over time. In conclusion, I strongly support SB 199 and urge you to pass it. Short-term plans provide real benefit to consumers. States that permit short-term plans have had better experience in their individual market since 2018. Kansas residents can receive additional protection if they're permitted to buy these policies for up to 36 months. Thank you again for the opportunity for me to give testimony. I look forward to any questions you have.
And thank you very much. Committee, we will now turn our attention to Michael Cannon with the Cato Institute. Michael, are you
I'm here. Can
online?
You hear me, Mr. Chairman?
We can hear you. Please restrict your comments to 3 minutes or less. We do have your written testimony in front of us.
Great. Well, thank you, Mr. Chairman. It's a pleasure to be here. I'm the Director of Health Policy Studies at the Cato Institute, where I've been for 17 years now. I've testified before the Kansas Legislature on many occasions, met many of you. I'm here to speak not in favor of or against a bill. We don't do that at the Cato Institute, but I want to give you some reasons why expanding short-term plans, extending the maximum contract term, and even allowing issuers of short-term plans to offer renewal guarantees is a good idea. In some, what these steps would do is protect the sick from discrimination on the basis of their medical conditions. The longer you extend the term of those plans, the longer you protect them from being re-underwritten and maybe charged higher premiums or having their coverage canceled. So when you extend the terms of these plans, you are expanding consumer protections. This is incredibly important because economic research has shown that Obamacare's supposed protections for patients with pre-existing conditions are themselves forcing insurers to discriminate against patients with expensive conditions like multiple sclerosis, infertility, substance abuse disorders, hemophilia, severe acne, and others. In fact, patient advocacy groups have further alleged that such discrimination occurs in Obamacare plans against patients with cancer, cystic fibrosis, hepatitis, HIV, and other illnesses. And we see this discrimination happening every time we hear about Obamacare plans limiting choice of doctors and hospital networks getting narrower and drug coverage getting skimpier under these plans. These are the forms of discrimination against the sick that Obamacare encourages. One of the victims of these types of discrimination, such discrimination, is a 7-year-old leukemia patient in Virginia named Colette Briggs. Her family has been struggling to get Obamacare plans to cover her cancer treatment, and it's been a struggle because Obamacare rewards plans that exclude the doctors and hospitals that Colette needs. When you expand short-term plans, you are protecting the short-term plans don't operate with those same incentives. Short-term plans have broader provider networks. They don't encourage insurers to discriminate against the sick in the ways that Obamacare does. And I would argue that Obamacare counts as junk insurance for that reason, whereas short-term plans can provide secure access to coverage, but only for the term of those plans. And secure access to care, but only for the term of those plans. And you will make that access more secure if you lengthen the maximum term of those plans and do what the federal government allowed insurers to do under that 2018 rule, which is to sell short-term plans alongside a standalone renewal guarantee that would say that when you reach the maximum 36 months, you can renew or enroll in a new 36-month contract without any new underwriting.
Michael, I need you to wrap up if you can.
Okay, I'll just go ahead and stop that there and say that that is how you protect the sick from being discriminated against, is you allow them these renewal guarantees that protect them against their premiums going up, against their coverage being canceled, or the type of discrimination that exists in Obamacare. And I thank you and the committee for your time.
Thank you very much for testifying today. We appreciate it. Committee, let me call your attention to either updates or new proponent written only testimony from 6 people on your agenda. We will now turn our attentions to the opponents. First, we have Katrina Black, who is a concerned citizen. Katrina, are you with us?
Yes, can you hear me all right?
Can hear you. Please keep your comment. We do have your written testimony, so please keep your comments to 3 minutes or less.
Thank you, Chairman and members of the committee. My name is Katrina Black. While I live in Texas, I'm here today to share my experience with a short-term health plan as an example of what Kansas consumers could face if this bill passes. In May 2019, I graduated from law school and moved across the country to start a new job. Right before I moved to Texas, I had a major surgery for a lifelong illness of stage 4 endometriosis. My school insurance took great care of me, and I was able to have my surgery fully paid for. I had it right before I graduated and moved. And for my post-op treatment, my doctor instructed me to get physical therapy, OBGYN check-ins, an MRI, and various prescription drugs in Texas. Because I was done with school and I was going to have a gap in insurance from July 1st through October 1st, I went to healthcare.gov to get a short-term health plan before my insurance with my new job kicked in. A pop-up on healthcare.gov asked for my zip code, and then I got transferred to the Texas marketplace. The minute I entered my phone number, my phone started ringing off the hook, and I did my research, compared with different agents. One agent, Cindy, was the first to get in touch with me. I told her about my surgery, told her I needed to have a plan where my physical therapists and doctors were in network and my prescription drug needs would be also covered. I also wanted to pay a higher premium for a lower copay since I was going to be seeing specialists 2 to 3 times a week. I gave her the exact, I even went as far as to call my providers for the codes, asked the agent if these codes would be covered under the insurance. And she said they would. Let me say that again. I was clear about my pre-existing condition, and she promised me complete coverage for my needed care. I also made this clear in my paper application for the insurance company. I put what had just happened with my health. So I started going to my PT visits 3 times a week. By the 3rd or 4th visit, though, the receptionist at my provider said the insurance company kept hanging up on them. And when I called them to find out why, they said, oh, sometimes there's glitches in our system. That's weird. I kind of just took her word for it and asked my receptionist to call again. She got through. But then I started receiving some really bizarre explanations of benefits, or EOBs, in the mail, saying I wouldn't be covered for missing code for the claim, or the dates don't match. And I would call and have to resolve it. Eventually, though, later, I got one really distressing EOB, which line itemed every coverage date over the summer and the fall, saying all would be denied due to a pre-existing condition. I was really shocked, and I called the company, reminded them that I was upfront about my illness in the application, and they said,
I need you to wrap up if you can.
Yeah. So in the end, I ended up having to pay $4,000 to $5,000 in bills that I had to pay out of pocket. That's on top of the $1,500 premiums that I wasted. And please oppose SB 199 to keep short-term plans from harming more consumers in the future. Thank you.
Thank you very much for being with us. Next, we have Peggy Johnson with the Susan G. Komen volunteer. Peggy, are you with us?
Can you hear me?
We can hear you.
All right, thank you.
Peggy, we have a lot of testimony today. We do have your written testimony, so if you could keep your comments to 3 minutes or less, we would appreciate it.
I'm going to talk as fast as I can. Thank you, Chairman.
Okay.
Thank you, Chairman Longvine and members of the committee. My name is Peggy Johnson. I appreciate the opportunity to speak in opposition of Senate Bill 199. So I am a longtime volunteer with Komen and the Kansas Cancer Partnership. I'm also a 9-year breast cancer survivor. Over the years, I've had the opportunity to assist women after they've heard that they had a diagnosis of cancer. You can imagine, nobody ever thinks they're going to have cancer. Most people, when they hear cancer, they worry about what effect it's going to have on them and their families, both emotionally and financially. It's going to be something that disrupts their lives, and it could be for a very long time. So there are lots of decisions that you have to make, you know, what treatment you're going to have, where you're going to have treatment, all those things. If you add to that your insurance may not pay for all, or certainly may not pay for any of your treatment, it further disrupts your life. So the concerns are that these plans put forward by SB 199 and extending them would hurt that peace of mind. So I'm asking the committee today, have you read your insurance policies? Do you know what it's going to cover? I'm wondering, unless you get faced with this, we often don't know exactly what's in there. I'm sorry, I just lost my, oh, hang on. Okay. So, so I also ask you if you realize that your insurance could be canceled the next year because you had a diagnosis of cancer or any other chronic disease. So an important part of all cancer diagnosis is early diagnosis. So do these plans provide that? Not sure. The Affordable Care Act provides for mammography as a prevention tool at no cost. Time has proven that through this, early access, early diagnosis, and treatment, costs have dramatically gone down. Since the pandemic started early last year, it's been notable that there's been a decline in women receiving their yearly mammograms. It's estimated that we're going to see an increase in late-stage breast cancer by as many as 10,000 as a result. So in 2012, I was diagnosed with triple-negative breast cancer. I knew what surgery I wanted, where I wanted to be treated, and I assumed I had good insurance. By the time I finished all of my treatment, which was a lumpectomy, 4 rounds of chemotherapy, 35 radiation treatments, the cost of my treatment was over $200,000. Now that's 9 years ago. My insurance negotiated, my insurance negotiated $66,975. That's what they paid. So I had good insurance. I'm going to say this quickly. Pre-existing conditions is a problem with these plans. My daughter was diagnosed with asthma at the age of 3. She's now 35. She has had a pre-existing condition for 32 years. I ask you.
I need you to wrap up if you can.
Yes, thank you. I ask you, look at these policies. We are concerned about pre-existing conditions. We're concerned about what they're actually going to pay. I appreciate the time to speak with you today, and I urge you to vote against Senate Bill 199.
Peggy, thank you for being with us today. Committee, we will next turn our attention to Carrie Rinker on behalf of 10 National Health Associations and Societies. Carrie, are you with us?
I am. Can you hear me?
We can. Please keep your comments to 3 minutes or less.
Of course. So yes, I am here to represent over 10 patient advocacy groups opposed to SB 199. Quite simply, this is bad policy at a bad time, but there is hope on the horizon. Specifically, I'd like to address some of Brian's remarks here that he made. The premium quote information that he gave is no longer true, and I'll share later in my remarks as to why. And also, some of the information he gave is directly contradicted by the National Association of Health Underwriters in a letter that they submitted in 2018 to the federal government regarding the extension of these plans. Now, informed choice and current existence of these plans was stressed during last week's testimony. It is true that there is a disclaimer for these plans. It is also true that people living with pre-existing conditions are keenly aware of their insurance needs and would not knowingly opt for this type of plan. However, we all have had experiences in life where we don't know what we don't know. Bad stuff happens. As Peggy shared, cancer happens, heart attacks, strokes, never expected, commonly capped. Further, we feel that these plans stray from the intent, which is gap coverage. You have written testimony there in front of you, you should, from previous hearings, from American Heart Association volunteer Tiffany. I wish she could have joined us today because, as you will read, she is passionate about protecting Kansas families. A pregnancy can be a joyous surprise, even if unplanned. Please think of these young families, the very demographic I've heard that these plans are geared toward, facing lack of coverage for their critically ill child. The gentleman that spoke about his 5 children being covered, I would bet that they didn't have congenital heart defect that he had to deal with. Pregnancy is not a qualifying life event for ACA coverage, and the costs of these congenital heart defect births, neonatal care, surgeries, they're astronomical. Once the child is born and looking at future expensive surgeries and care, it is true that these families can move to the ACA pool due to a child being a qualifying event. But that act in and of itself, while good for the family, is creating a de facto high-risk pool of the market and increases costs for everyone in it. Affordable coverage is a concern for those who have lost their jobs and even early retirees. That's why insurance relief was included in the American Rescue Plan. And I realize there's plenty of elements of that legislation that members of this committee would never endorse. But the truth is that it will reduce the premium gap between short-term policies and ACA plans. The ARP provides 100% COBRA premium subsidy paid directly to the employer, closing the coverage gap and avoiding any confusion. The ARP caps premiums for benchmark ACA compliant plans at no more.
Carrie, I need you to wrap up if you can.
I will. It caps these plans at no more than 8.5% of household income. And in fact, a 55-year-old living in Overland Park earning $48,700 a year would pay $326 a month for a silver level plan, which is $1 less than the gap plan that was mentioned in this committee on March 18th. And they would avoid the anguish, the risk, the exposure, and the horrible situations that these folks have shared about today. Thank you for the opportunity to give these remarks on behalf of the coalition. I'm happy to be here for questions whenever.
Great, thank you very much.
Occurs. Thank you.
We will now turn our attention to Courtney Eiderich. Sure I butchered that. Sorry, Courtney. She is with the MS Society.
Thank you, Chair Longbine and committee. My name is Courtney Eiderich. I am the Government Relations Advocacy Chair for the MS Society, and I currently live with multiple sclerosis. At the age of 32, I was a healthy mom and just thought that I was experiencing sciatic pain for a couple of days and ended up with a diagnosis of multiple sclerosis. And while I would have maybe been a perfect candidate for one of these short-term plans, MS is quite unpredictable. It happens without any known cause or cure, and more importantly, is progressive. So at any point, I can not be able to see or to walk, and without access to disease-modifying therapies, someone with MS would just be accelerating this progression. So every minute matters. I currently take a medication called Tysabri, which is a monthly infusion. It is a therapy that has a protocol to it for compliance. It is includes monthly blood tests, several MRIs throughout the year, several specialist visits, and that's just for people who are stable on the medication. That doesn't include the extra costs that come with an exacerbation or a hospital stay along the way. But the price tag on just my medication is $150,000 a year. Without comprehensive insurance, my disease is simply just unaffordable. And without coverage or with a gap in coverage of any kind, every minute matters. So after 11 years of being a part of the ACA, this is the only place that I was able to buy insurance. And so when people talk about it being discriminatory, short-term plans, association health plans, all of the other plans that are out there will not cover my condition. It would have been excluded. So this is the only place for me to be. So I don't feel that that's the place that's being discriminatory. But more important, a lot of the plans that are out there, like the short-term plans that are being proposed, don't have the same comprehensive prescription care coverage that I would need, even if it covered my diagnosis. Some of the plans that I've run across only cover generic drugs. Some of them cap out at $5,000 or even $7,500, and that wouldn't even cover 1 month of my prescriptions. I am genuinely scared for people that end up with a diagnosis like mine, thinking that they're healthy and have this short-term gap coverage that can now be extended up to 3 years. It's really essentially giving them a false sense of security for what they think is insurance coverage, when in fact it is not. I really think that we should be protecting our most vulnerable Kansans, and I urge the committee to please oppose Senate Bill 199. Thank you.
Thank you very much for being here today. We appreciate it. Committee, let me call your attention to written-only opponents from Sunflower Health. Would also like to call your attention to previous testimony from February 25th and March 18th that are in your folder. At this time, we will close the hearing on Senate Bill 199. What is the committee's pleasure on 199? Senator Gossage.
I move we passed Senate Bill 199 favorably for passage. Oh, wait, sorry, I have an amendment.
You're doing well so far. Is there a second?
I can say, though, that I like to move it, and then we have the amendment, correct?
Correct.
Thank you, sir.
So Gossage seconds, Gossage moves, Hildebrand seconds. Now discussion. Senator Gossage, you have an amendment?
I do, and if we could pass that out. And while she's passing that out, let me just verify. This is a very short bill, and on the second page, it requires a certain wording to be on each of the short-term medical plans. But in reviewing the federal regulations last evening, I noticed that there are 2 sets of wording that is already required, and short-term medical plans already have these. They are required to be on the front page of the application. It's already there. We don't need to have our separate wording. So just the wording that was put in. And by the way, I should mention, this bill passed the House committee last year, this exact bill. So that language was put in actually by Blue Cross Blue Shield of Kansas City last year. And since it's already been put into federal regulation, it's unnecessary. That's the only reason why it was stricken. Thank you.
Questions on the amendment? Senator Gossage, would you like to make a motion on the amendment?
Yes, I move my amendment.
Is there a second? Senator Peck seconds. Any discussion? Seeing none, all those in favor of the amendment say aye.
Aye.
Opposed, no. Motion carries. We're back on the bill. Was there any further discussion on the bill? Okay, seeing none, all those in favor of passing out Senate Bill 199 favorably for passage as amended, say aye.
Aye.
Opposed, no. The bill passes. Okay, chair is in doubt. All those in favor signify or raise your right hand, please. As in favor of the bill. All those opposed?
Order.
Sure.
Just for clarification, I know there have been instances on the floor where you've recused yourself from votes where your business is directly affected. Is that not appropriate in this situation? Because I believe we have several people on the committee who would be selling these policies. So I guess I'm asking for clarification in that regard.
Senate rules allow each senator to make their own decision whether they should recuse themselves from the vote or not. It's up to each individual senator to determine whether they should or should not vote. Okay, Senator Hildebrand.
Thank you, Mr. Chairman. Although I am a licensed insurance agent, I do not sell health insurance. Thank you.
Senator Fagg.
Thank you, Mr. Chairman. I'm also a licensed insurance agent, but I haven't sold insurance for a while, and I needed to have it in banking. So I've been through their continuing ed and their ethics stuff, so just want to make that.
Okay, committee, we will not meet tomorrow, but we will meet on Monday and Tuesday at 9 a.m. In this room, and we will be dealing with the new trust bank proposal. I emailed you a presentation yesterday, I believe. If you could try to make yourself a little bit familiar with it. It is kind of complicated. It is a concept that is new to Kansas, and so we will begin working or hearing that on Monday. Final vote was 5-3. Anything else to come before the committee today?
Mr. Chair?
Yes.
I'm sorry, before you adjourn, you didn't, when you took account, you didn't announce, and we can't see the rest of the committee when we're virtual, so could you announce the final vote so I can actually know?
Final vote was 5-3 in favor of
Thank
passing
you.
out Senate Bill 199 favorably. Committee, we are adjourned.